I'd like to thank everybody for coming today. This is an important for some of us talk at 12 because it represents a very long-standing, broad, and deep collaboration between the Bronfenbrenner Center and our medical college. And in fact, we think it's arguably the longest and broadest one, where there's a lot of co-mentoring, and people are actually stay on PhD committees for a while, and we have meetings there. And one of the great outcomes of that collaboration has been what's called a T32 training grant from the National Institute on Aging, in which 2 postdocs are brought in each year and stay for 2 years. So there are 804. And Libby and Heather are this year's incoming class, of course, and they're completing the first year. So we have them come here to meet people and give presentations about their work. For those of you, I'm glad to know we have some folks from the community here and others we don't always see. You can find information about the Bronfenbrenner Center and these kinds of talks easily on our website, so please feel free to join us. I'd like to say, too, that the folks here in Ithaca, perhaps they can just sort of raise their hands, who are involved in this large training grant are Elaine Wellington and Anthony Ong and Kurt Lickenhoff. And so I think for all of us, it's been a great experience. What we're going to do is, for those of you who might not look at the sign carefully, because we have 2 presenters, so we usually end at 1, and today we're ending at 1:15. If you have a 1 o'clock commitment and you have to slip out, please just feel free to do so, but quietly, if you will. And also, because we have 2 presenters, we thought that, like, rather than interrupting them with questions, that we would do the presentations and you could hold your questions until we're done. I'll give you a little high sign at sort of, the 23-minute mark if that is necessary. But it won't be. So you're completely concise and compact. So I don't know who was going to go. Heather, are you set to go first? Yeah. Oh, so Heather Derry is one of the T32 postdocs, and she completed her PhD in psychology at Ohio State, where her dissertation work evaluated how physical fitness affects cognitive function among post-surgery breast cancer survivors. As part of a very well-known lab that looks at the physiology of stress and health. And she then completed a clinical health psychology internship at the Cleveland VA Hospital. And her current work aims to identify and reduce stress and emotion-related barriers to patients' understanding and management of health. And she's going to talk to you about that. Elizabeth, known informally as Libby Luth, who received her PhD in sociology from Rutgers University. And she also worked with a very well-known group that looks at end of life care. And she's a medical sociologist, and her research focuses on the social determinants of health disparities over the life course, especially among older adults and at the end of life. And in her postdoctoral fellowship, she's expanding this work on social disparities in health and is focusing on individuals living with and dying from Alzheimer's disease and other dementias. So with no further ado, Heather, take it away.
Thank you, Carl. And Libby and I would really like to start by thanking you all for inviting us here to speak with you about what we've been working on. I also have to say we're both really just glad to have you all here on such a beautiful day during lunch, during a hectic time of year. So honestly, this is very, we just really appreciate your time. So we're looking forward to talking with you. As Carl mentioned, I'm a postdoc at Weill Cornell, and we, have really benefited even from just the short time that we've been up in Ithaca and talking ideas over with folks, and this is really exciting to be able to have the back and forth between the institutions. At Weill Cornell, I've been primarily working with Holly Krigerson, and I'm going to be talking today about ways that I'm working during postdoc to bring my research more from a laboratory-based stress background into more of a clinical setting. And so I'm particularly glad to be doing this here because you all are really doing such great translational work, and I know I'm going to benefit a lot from your thoughts on this and what I hope will be kind of a continued dialogue. So just to get started, I'd like to talk about some overall goals that I'm hoping to achieve with my research. So I'm hoping to inform a patient-centered care model where both patients and providers are important partners in managing a patient's health, both from prevention all the way to chronic illness and end of life. And what I'm really interested in is kind of in the top left-hand corner here in fostering the informed patient who is activated and able to make educated decisions about their health care. So while I'm going to be focusing in on that patient piece, I do think it's important to note that, you know, there are a lot of other factors and interactions at play here. What I'm really wanting to do is to better empower patients to become knowledgeable about their health through the interactions that they have with their providers. And based on my background, what I'm most interested in right now is how stress and emotion may at times interfere with patients' ability to gain information from those visits. So this has kind of led me to a couple of different research questions. One being, how do stress responses impact how patients process clinical information during their doctor's visits? And two, we have some effective stress management strategies for reducing anxiety and reducing stress reactivity. So what effect might those have in these settings for helping to foster patients walking out of the door as more informed consumers of their care? So today I'm going to start by talking about some context for addressing that within the context of advanced cancer. I'm going to speak a bit about laboratory-based research that suggests that stress can impact the way that we think and process information. Then I'm going to bring it back to some clinically relevant topics of how that might play out in a discussion in the cancer setting about discussions of imaging results, and then share a bit about some works in progress and some future directions. I should say as well, you know, today I'm going to be focusing on cancer, but I'd be really interested to also hear from you about if there are other ways that you see this being relevant in areas that you work in or in your practice or experience too. Okay, so to get started, what we know is that cancer is the second leading cause of death here in the US behind heart disease, and that age is a primary risk factor for cancer. What you can also see here are some projected numbers in terms of who it is that cancer affects over time by age. And these are some predictions for the year 2040 that show that cancer is increasingly affecting older adults, where over 75% of those affected by cancer are estimated to be over the age of 65 by that time. So this is really quite an important disease for older people. To zoom in a little bit more on the very specific case of advanced cancer, the National Cancer Institute defines this as a cancer that has spread to other parts of the body and that usually can't be cured or controlled by treatment. Also suggesting that these patients typically have a higher physical health burden, may have a limited life expectancy, and so this is really quite a difficult and complex area for patients and their families to adjust to, obviously. Holly Priggerson's group has really done a lot of work in shining a light on gaps that can exist in terms of what patients may understand about their illness process and what their providers may understand, or how that plays out in real life. And so just to kind of graze the surface, there are a lot of factors that may create kind of a disconnect between what the patient may understand about their treatments or their course of their illness compared to providers or the expected course. And those range from clinical factors, like whether that's been discussed in appointment with the patient, who discussed it, sociodemographic factors. There are some differences based on race and gender. Also personal and religious beliefs, of course, come into play when we're talking about serious illness and end of life. And of course, family and caregiver factors as well. So I bring this up to really just paint this really complex picture and suggest that I'm interested in kind of a piece of the puzzle, but there are a lot of factors to consider. Okay, just to illustrate one finding that kind of illustrates this gap, in one study that was done in a different center, advanced cancer patients were recruited specifically when they were receiving treatments that were not intended to cure their cancer. So in this case, the treatment's usually intended to like slow the growth of the cancer or help the patient manage symptoms. And among those patients who were receiving treatments that weren't intended to cure them, a little over half of patients responded that they thought that the intent was to cure their cancer. So this really illustrates kind of a disconnect with what the treatment goal and maybe the provider's understanding of that treatment was and what the patient's understanding was. And I think maybe even more importantly, it can also illustrate that gap between what the patient knows and what they say that they may want to know. So for example, in this same study, when asked how much they would want to know about their cancer and their treatment, most patients, over 75%, responded that they would like to know as many details as possible about their diagnosis and treatment. And so I think that gap between what patients may want to know and what they may know is also very important to address. Okay, and so thinking about the context in which many of these concepts are discussed in appointments with physicians, what we know is that many times cancer patients, other patients with chronic illness, other patients without chronic illness are typically a bit stressed or anxious about going to the doctor. And so thinking about what state patients may be in when they walk through the door, I think could be important. So here is some item level data from a sample of people who were either in remission or had current breast cancer. And what you see is that about 1 in 5 of those patients reported being often or very often afraid of their disease getting worse. Which certainly sounds very normal, right? Most people would be afraid of that. Another piece that was asked in this study was about how often do you get nervous for physician appointments or for periodic checkups like blood tests or scan results to monitor your disease. And almost half of people reported that they were often or very often anxious coming into these appointments. So I show this mainly to kind of talk a little bit about the emotional context to suggest that these types of appointments where patients are discussing the course of their illness or the results of their scans with their doctor can be very stressful and anxiety provoking. And so what insights can laboratory-based research tell us about how our thinking may or may not change when we're under stress? Just to kind of illustrate a bit for folks who aren't as familiar with laboratory-based stress research, essentially the goal is to simulate a stressful situation in the lab so that we can study what happens to the body, what happens to people's emotions, what happens to their thinking in kind of a controlled way, and either compare that to the patient's baseline or compare that to a control condition to better parse out what the effects of stress are. And so one particular task that's often used that I'm going to be referring to in these studies is called the Trier social stress task. And essentially what this is a participant is in a study in a laboratory setting. They're given pretty short notice to prepare a brief speech that they're told they're going to be delivering in front of a panel. And the speech usually has some self-relevant component, like why you're the best candidate for a job, for example. And they're told that they're going to be delivering this speech in front of a panel who's been trained in like behavioral analysis or can really detect anxiety or performance well, and kind of creates a high stakes situation that the person is also being video recorded oftentimes in these studies and told that that tape is going to be analyzed later. So this really creates kind of a social evaluative threat to the person. And it's also, typically kind of a unpredictable or uncontrollable task. And then afterwards, the person is also asked to do some mental arithmetic. So the whole process lasts maybe 15, 20 minutes. So, it's not lost on me that I'm in a sort of similar situation right now. Although, luckily I've had more time to prepare, and you all are not a stoic audience, which these folks are typically instructed to be. So the idea here is that this does also provoke a physiological response, so that kind of fight or flight autonomic nervous system response that also then prompts further neuroendocrine and immune changes. And so one thing that I think is important to keep in mind with these types of tasks is that people respond differently based on a variety of different factors. So not everyone is going to have the same type of physiological response to this task. And there's a wide variety of research being done in this area. This was something that I became really interested in earlier on in graduate school. And some examples of factors that influence the way that we respond to stress in that moment are our early life experiences, chronic stressors that we may be going through, mood and anxiety at baseline. This is just an example from some project that I had worked on in my graduate mentors lab, Jan Kiko-Glazer's data, that we looked at how someone rated themselves on a social ladder. And those that perceived that they were less than others on that ladder, or lower status, had higher reactions to that stressor than those who rated themselves as better off. And they also perceived that stressor to be more threatening or less able to cope with it. So this is really an area that I'm very curious about how people differ in their response to even a standardized task that's the same for everyone. And so what do these types of studies tell us about how stress impacts cognitive function? This is an example of a study that was done to get at that, where participants were brought into the lab. They either underwent that stress task that I mentioned earlier, or they completed a control task that was basically the same, except for there wasn't a panel. They were just completing these tasks on their own, which has been shown to be less stressful. And then they completed a working memory task called the NBAC task, which basically requires a person to keep monitoring and updating information in their mind in a variety of different types of trials that are either kind of more or less challenging. And what they saw was that in the stress condition, it was, first of all, more stressful. These participants had a greater cortisol response to the stressor, and they reported more negative emotion in response. They also had slower reaction time on this particular task, which is actually a bit more, the way it was constructed here was a bit more challenging than some simpler tasks. They also made more errors. So this really is an example of kind of a broader literature showing that under stress, our working memory, our ability to kind of monitor and update information in our mind under difficult conditions becomes a bit more challenging. And this has been replicated in other studies and in other areas. And it also has been shown to impact our ability to kind of switch between different types of information or different types of tasks. Okay. In addition to that, and not just kind of these cold, hard cognitive tasks, we also know that the emotional context can play a role. And so many folks in the room are likely very familiar with the interface of how stress and emotion are both really important to account for here. So I'm really just kind of grazing the surface. But this is an example of a similar setup for a study where instead of the working memory task, folks read either an emotional story or a neutral story. What they saw was that folks in the stress condition actually had better memory for the emotional components of a story than the controls did, and the reverse was true in the neutral story. So in that particular condition, control participants outperformed those who were stressed. So this is really kind of a complex area. There's a lot to account for, I think, and there's also even a separate literature suggesting that our attention can shift based on the emotional state that we're in. So I think that the prospect of applying this to more clinical-based settings kind of introduces some complexity, but that there can be some exciting questions that we can ask. So how does this effect extend to clinical experiences? I became really interested in this when I was working on my dissertation study. As Carl mentioned, I was working primarily with women who had earlier stage breast cancer and who were being recruited for our study shortly after they had received their surgery, but before they received any chemotherapy or radiation treatment that often comes afterwards. So they're in this kind of gap time where they were learning a lot of information about their disease, learning a lot of information about treatment, and having a lot of numbers probably given to them. And what I noticed in kind of just anecdotally working with these women was that they seemed to comment a lot about just how much information they were receiving, that this was overwhelming to them. It was really difficult to wade through. They felt kind of just like cognitively burnt out at certain times. And even just in the study, again, this is all anecdotal, but it just felt a bit more scattered than maybe some other participants that we had worked with. So this just kind of prompted the question for me about how the stress of what they were going through at that time could impact their cognitive function, and particularly how they're able to engage with that information in a clinical visit, where you're often receiving a lot of information, right? So this kind of brings us back to talking about this in more of a clinical setting. Again, keeping in mind that most patients, or almost 50% of patients in this study, report that they are anxious coming into these visits with their doctor to learn information about their disease. In particular, I'm interested in how that level of stress may impact their understanding of the information in those appointments, and or just behaviors during those appointments. In particular, one type of appointment seems to kind of gain a lot of attention in terms of anxiety. There's a phenomenon that's been referred to as scanxiety, where we see that people are coming in for routine monitoring of their disease by the process of getting a scan and then discussing it with the physician, tend to report that that's a very anxious time for them as they wait for the result to find out if their cancer is getting better, worse, or stable, or how their treatment's working. And this has been shown in a variety of studies in a variety of different ways. So kind of zooming in more on this type of appointment where scan results are discussed. This is some data that is drawn from a qualitative study where the researchers audio recorded these types of visits with participants in their oncologist's office, and then they coded how the time was spent during those visits. And probably can't see it, but this is, the red shows how much time was devoted to discussing the scan itself and what it meant for the patient's illness. And you can tell that's a pretty small chunk of the whole visit, right? So in this case, we're talking about maybe a minute and a half or so on average, whereas there's, you know, a lot of shifting that's going on between other topics too, like just talking about symptoms or logistics, as well as here the yellow is treatment options. And so in thinking about this, excuse me, I show this to kind of illustrate that these are really quite complex visits, where a person might be asked to take in a lot of different types of information, switch back and forth between types of information. And I would argue that this is likely a cognitively demanding situation for the patient. So this has led me to ask a similar question as I've been getting started here at Weill Cornell, which is how do stress and emotion impact patients' accuracy for what the main message of their scan results visit was. So kind of sorting through all of the different information that's being given to come up with a main message of whether my disease is getting better, worse, or stable. Sorry. Okay. And in order to begin looking at this, I've been working with Holly and Paul on some archival data that was collected as a part of their Coping with Cancer 2 study, in which they did assess cancer-related emotions. And so I'm going to show a little bit of that data that we're finding now. It's very preliminary, so it's still kind of in draft form, but I did want to share it with you all today. So just a little bit of background about the study. Participants were adults with advanced cancer who had metastatic cancer that was shown to have gotten worse on at least one treatment. And in this particular study, it was a multi-site observational design where patients were followed up for a period of time. But the earliest part of the study was surrounding a scan results appointment, where patients were first interviewed prior to the appointment. Then they came in to meet with their oncologist about the results of their scan. And then both the patient and the oncologist afterwards were asked, what did the scan results show? And so beforehand, they were asked, to what extent do you feel anxious or sad about your diagnosis? And then afterwards, an example that was asked to the patient was, basically, your doctor said your cancer is worse, cancer is better, stable, or other. And so what we've done so far is we've coded accuracy based on comparing the patient's response to that question with the oncology provider's response to get a sense of how those two responses agreed with each other and how accurate the patient was for that main message that the provider was endorsing. And so just to show some very preliminary results here, what we've seen is that the majority of patients are accurately reporting their scan results from those visits when we compare them to the oncologist. So this is quite encouraging that most people are getting that and extracting that main message from the visit. What we also see then on the flip side is that close to 30% are inaccurate for that result or had difficulty summarizing this in some way. So for an example, one patient responded other, even though their provider was able to categorize this. And they said something like, it looks stable on the scan, but this other marker says it's getting better. I'm not really sure exactly, is kind of the message that was sent about that. And the next piece that we've been looking at more recently is how do those emotion variables that were collected prior to the visit predict who may be more or less accurate for those scan results. And again, these are just some kind of initial trends that we're seeing, but what we're seeing is that patients who previously rated that they were more sad about their diagnosis actually had increased accuracy for the results compared to the physician, whereas in the case of anxiety, it was kind of the reverse. So people who were rating their anxiety as higher were a bit less accurate for their results. So we're still kind of working on this and teasing apart, in what circumstances is this the case, and also controlling for some other factors in the study. But I'm really just taking this to be some, kind of initial data suggesting that there may be something going on here with stress, emotion, and understanding. So in terms of some future directions that I'm working on, I am interested in moving forward and kind of expanding on this line of work to examine responses in a few different ways. So if we are taking, this idea of an imaging scan results discussion, I'm interested in learning a bit more rather than how patients rate emotion and understanding like days or weeks away from their appointment, but more about how they're feeling more close in time to the moment of when things are being discussed with them. Of course, doing this in a way that balances being precise in measurement with also feasibility and burden on participants, really trying to think about ways that we can ease this process of data collection. So there are a few ways to collect some physiological data that might not be very intrusive for folks, as well as having ratings of emotion that are fairly user-friendly. So this is just an example of a way of rating emotions that was developed from Cornell and Cornell Tech folks. And this is a piece of a project that we are submitting as part of a larger cross-campus grant. So I'm really excited to be working with a team on this, including Anthony, Elaine, and Alan. So well, fingers crossed on that. We're hoping to kind of move forward. Another piece of what I'm interested in then is, if these types of responses do have an impact on patients' understanding of the information, is it possible that we may be able to intervene to help them manage stress better? So in this case, we do have some great relaxation strategies that work well, like deep breathing or meditation, that have been shown in other populations to help people manage stress and anxiety. And so I'm wondering if we employ those here, would it help not only to manage stress and anxiety, but possibly to have patients walk out with a more accurate understanding of their illness. Okay, so just in summary, what we've talked about is how stress can impact our thinking over time and how that might be particularly relevant in a clinical visit. Some implications of that include learning a bit more about how stress is impacting patients during those visits and hopefully finding a way to intervene to help manage that better. So with that, I'd really like to thank everyone involved in the T32 Fellowship for the opportunity to look at these questions, especially the faculty that I've been working with most closely so far, Holly, Carrie, Paul, and Elaine, folks at the Center for End of Life Care, as well as the postdocs that we share a room with. We have quite a good group and I learn from them every day, as well as the geriatrics division staff and of course the participants who gave their time for this work. So thank you.
Why don't we go directly ahead and then please make note of your questions and we'll have time at the end.
Okay, so I want to echo less eloquently what Heather said at the beginning, to thank you all for coming today, for the invitation to have the opportunity to share a little bit of our research and what we're working on with you all, and hopefully to hear some feedback from you all about what you have to say. As Carl mentioned, I'm a sociologist, so I am a stranger in a strange land in an academic health environment, but my background is in disparities and health, and particularly end of life. So at Weill Cornell, as part of my postdoctoral research, I'm going to be focusing on patients that are living with and dying from dementia. So just to give you sort of a roadmap, I'm going to start by giving you a little bit of background, throw some facts at you about what it's like to live with Alzheimer's disease and die from it. I will also talk about what it's like to be a member of a racial and ethnic minority group in terms of aging and end-of-life care. I'll try and put the two together, which is sort of where my research sits at the intersection. I'm going to share a little bit about some studies that I've completed since I've joined Weill Cornell with some sort of unexpected and surprising results, and then talk to you about some current research projects that I have going on with some folks at Weill Cornell and where I hope to go down the line. So, okay, and I'm trying to channel my grandmother who's like, slow down. All right, so we'll start with a background on Alzheimer's disease and what it's like to live with Alzheimer's in the US. So this is just the crude death rate for 100,000 people for causes of death, the top 5 causes of death amongst people 65 and older. And as Heather mentioned, and you can see that heart disease and cancer are leading causes of death for older adults. And the other two that we'll see are chronic lower respiratory disease and stroke. Down here, the green line at the very bottom that you see is Alzheimer's disease. One thing I just want to point out about this is that overall, you can see that the leading causes of death are trending down. So heart disease and cancer are still major causes of death, but they are on the downtick. The same with stroke, whereas COPD has sort of stayed stable since 1999. These data are from 1999 through 2014. And you can see, maybe you'll be able to see that Alzheimer's disease is the only one that's sort of ticking up, right? So all of that to say that it is a leading cause of death, but it is also a growing cause of death amongst older adults. This is in part because as life expectancy increases in the US, one of the leading risk factors for Alzheimer's is age, right? So only 4% of people with Alzheimer's are under 65 years of age, compared to 82% that are 75 and older. In terms of living with Alzheimer's disease, Alzheimer's is a little bit different from other causes of death in that it has a particularly long and burdensome disease trajectory. So the average time of survival from diagnosis is between 4 and 8 years, but you can live as many as 20 years or more. 40% of the time that you're alive once you have the diagnosis is spent in the most severe and advanced stages of the disease. So it carries a heavy burden with it. There are high rates of institutionalization amongst people with Alzheimer's. So 75% of people 80 and older live in an institutionalized environment. This is compared to 4% of the general population aged 80 and older. And there's also, with all of this, there's a really heavy caregiver burden. So the impact of this on family members and loved ones of people with Alzheimer's is huge. So nearly half of caregivers report that they have been in their caregiving role for 6 or more years, which aligns with the average time to survival of the average survival time of 4 to 8 years. And 60%, so nearly 2/3, report that they have high or very high emotional stress related to their caregiving. In terms of dying from Alzheimer's disease, we know that I'm super uplifting in every time. We know the picture isn't so good. There are high rates of nursing home death, so 2/3 of people with Alzheimer's die in a nursing home. This aligns with the high rates of institutionalization, so not super surprising, although it does mean that 1/3 of Alzheimer's patients do not die in a nursing home, which is not a non-significant proportion. Care for patients with Alzheimer's is incredibly expensive. So Alzheimer's patients represent less than a fifth. They represent about 18% of hospice patients, and they account for 25% of Medicare spending. So there's a disproportionate amount of resources that are spent. In part, the reason for this is that because of the long trajectory and difficulty with diagnosing end-stage dementia, hospice stays for people with Alzheimer's tends to be much longer than for people with cancer and other types of diseases. So the average length of stay for a hospice, for an Alzheimer's patient in hospice is 104 days compared to only 46 days for a cancer patient. What kind of care, right, do people with Alzheimer's get? Again, I wish I had something positive to say. It tends to be very aggressive and burdensome. So people with Alzheimer's disease are at increased risk of burdensome transitions between care settings. So moving from a home to a hospital, from a hospital to a nursing home, which can be incredibly difficult at end of life. They're at increased risk of hospitalization, of dying in a hospital, of having a feeding tube or mechanical ventilation at end of life, and of exhausting their hospice benefit. So this 104-day average stay actually can extend longer than that and be somewhat problematic. So the hospice benefit, many of you may know, is 6 months or 180 days. You can be recertified for longer, but there is a not insignificant proportion of the population that exhaust that benefit and then are kicked out. So imagine, right, you've gone through this difficult decision and process with your family to accept hospice care, you're at end of life, you're sort of switching gears, and then 6 months later, your family member is, still with you, which is great, but no longer eligible for hospice, which causes sort of emotional stress and burden. So all of this points to the need, and because of the nature of cognitive impairment, that Alzheimer's is a little bit different in end of life from other diseases, to the extent that almost all the decision making is done by somebody else, right? It's not the patient, which is an incredible burden, can be an incredible burden on family members. And it really underscores the need for advanced planning at the early stages of disease, right? Which is not something that people want to do in advance, that they tend to do in advance, or that they tend to think of, right, when they get that difficult diagnosis. Okay, so that's a picture of Alzheimer's. I'm going to switch gears and talk a little bit about living with racial and ethnic minority status in the US. So this is the US population over 65 by race and ethnicity in 2016, which is the bar on the left, and the projection for 2060. And that Hispanic white to the blue, right? So what we can see is that 2 years ago, the population of the racial and ethnic minority population was just under a quarter. This is expected by 2060 to more than double, and racial and ethnic minorities will be just under half of people aged 65 to 84. And when we look at the oldest old, we see the pattern repeats itself. So it's the same for people 85 and older. So again, as with the Alzheimer's population, the proportion of individuals that identify as racial and ethnic minority statuses in the US is growing, right? And it isn't growing amongst older adults. We know that there are a lot of well-documented disparities in health outcomes based on race and ethnicity. Since I talk about end of life, I figured I would just pull one out to talk to you about, and this is mortality, right? So related to mortality. So these are average life expectancies for individuals broken down by race and by gender from 2006 to 2015. And what we know, right, is that women tend to live longer than men. So you can read this, the females tend to be, the higher bars in terms of years of life expectancy. But what we also know is that there are differences in life expectancy based on somebody's race and ethnicity. So among non-Hispanics, Black persons have shorter life expectancies than whites across the board. So the difference for women is 3 years. So non-Hispanic white women are expected to live 81.1 years, non-Hispanic Black women 78.1, and the burden for non-Hispanic Black men is even greater. They live 4.5 years less time than their non-Hispanic white counterparts. So we have a growing population, right, with a disparity in lots of different ways, but one of the most salient is the length of time that they live. So we're sort of already behind the curve in terms of addressing a potential gap. Dying for individuals from racial and ethnic minority groups, similar to with Alzheimer's, it's a very similar picture. So members of racial and ethnic minority groups are more likely to receive aggressive and burdensome care. Black individuals are more likely to be hospitalized, to spend time in an intensive care unit, and they also have more expensive lengths of stay during their terminal hospitalization, which is a marker for aggressive and burdensome care. They are also less likely to be able to access the type of care that can lead to higher quality of life at end of life. So there is a disparity in terms of hospice enrollment. So about a third of non-Hispanic Black and Hispanic Medicare decedents are enrolled in hospice relative and compared to non-Hispanic whites, where it's just under half, right? So another place where there's room for sort of lessening the gap. Finally, I alluded to this idea of exhausting the hospice benefit. So overall, amongst people that receive hospice, 1 in 5 experiences what's called a live discharge, which is where you leave hospice for a reason other than death. And African Americans in particular are at higher risk of this live discharge of leaving for reasons other than death. In terms of planning for end-of-life medical care, so we talk about this planning, what's called advanced care planning, and I'll talk about that a little bit more in a minute. But it has been shown to sort of really do a good job of reducing aggressive and burdensome care, and also helping patients achieve care at end of life that's concordant with their wishes. And there's a disparity here as well. So non-Hispanic Black individuals and Hispanic individuals are much less likely to plan for end of life than non-Hispanic whites. Okay, so it's bad, right? If you've got dementia, it's really not great if you're a member of a racial and ethnic minority group. And my research looks at sort of as sociologists, we love intersectionality, right? It's like, how can multiple statuses how do they layer on top of one another? And my research sits at the intersection of Alzheimer's and racial and ethnic minority status. So one of the things that I'm going to share a little bit about what we know, right? But one of the things that I find exciting about this area of research is that there's a whole lot we don't know. There actually isn't a lot that's been done on this particular population. So this shows the prevalence of cognitive impairment by racial and ethnic group for different age groups. So the blue bars are African Americans. So red or pink is Hispanic, and the green bar are whites, right? And this comes from a large nationally representative study, the Health and Retirement Study. Some of you all may be familiar with this. But basically the picture that you can see is that regardless of the age group, that African Americans and Hispanics have a higher prevalence of cognitive impairment relative to whites. And that as you get older, right, that disparity, that gap widens over time. So this hints to the idea that there is possibly sort of a dual burden of having racial and ethnic minority status with regards to Alzheimer's. Members of racial and ethnic minority groups, in addition to having a higher prevalence of Alzheimer's, also tends to be diagnosed at later stages of Alzheimer's. So this makes them not eligible for the few medications that are available that may slow the progression of the disease, and oftentimes makes them ineligible for clinical trials, which means that we are building a body of knowledge, right, that in which people that are overly represented in terms of being affected by it are underrepresented in terms of contributing to the knowledge about what to do about it. They tend to receive more aggressive and burdensome care, so there's indication of dual burden, and they use hospice and palliative care less. So we see sort of similar trends. So this leads me to a couple of questions that I like to, that I've been thinking about in my past research and what I'm working on now, in terms of like, what is the effect of these types of statuses of Alzheimer's and racial and ethnic minority status on perceptions of quality care, and what is the role of advanced care planning, and how might advanced care planning help in terms of reducing some gaps? So I wanted to share with you information from 2 studies that I've completed since I've been at Cornell that have some sort of unexpected findings, and I'd love to hear y'all's thoughts on why this might be the case. And these studies have sort of set up, right, the work that I'm doing next as I go forward. So for these studies, I use data from the National Health and Aging Trends study. Is anybody familiar in the room familiar with that study? Got a couple of guesses. If you're not familiar with it, it is a fantastic study. It's got a lot of publicly available data. So if this is sort of in your area of interest, I encourage you to check out the website. But this is a nationally representative sample of Medicare beneficiaries aged 65 and older living in the contiguous United States. It's a prospective and longitudinal study. So it started in 2011, and folks answer questions every year. They're in the field or about to go into the field for 2018, but there's data available from 2011 annually through 2016, and those are the data that I use. The study itself focuses on aging and functional decline, and sort of the goal is to track how that happens in an aging population over time. For my purposes, luckily for me, for the individuals that die, a family caregiver or another person familiar with care at the end of life answers a retrospective question about what happened, questionnaire about what happened in the last month of life. And so those are the data that I use. I wanted to also sort of go over 2 key concepts. The first is quality of end-of-life care, and what do we mean? Because that's something that gets standard. Well, we want high-quality end-of-life care. Well, who doesn't want high-quality anything? But what does that mean, right? And we might be inclined to argue that it means something, that end-of-life care is very personal, and that it means something very different for everyone. However, surprisingly, sort of regardless of who you're asking, whether it's the adult population, whether it's seriously ill individuals, the caregivers, healthcare providers, whether it's a study of cancer patients in the US or patients, I've found studies on defining quality of life in Iran, right? So all over the board, there are some key components. People say that they want to avoid pain and suffering at the end of life, right? So they don't want unwanted symptoms like pain, breathlessness. They don't want to feel sadness and anxiety, pretty universally. They also say that they want to be treated like a dignified person at end of life. They want to be treated with respect. They want to be kept clean, right? They want to be treated like a whole person. The one part that is a little bit different in a US context and increasingly in a Western European context, but maybe not in the rest of the world, is that they want to be informed about their condition and they want to be involved in decision-making about their treatment and about what's going to happen to them. Now, since the data that I use are from the US, I do include this informed and involved decision-making as a construct in terms of what's included in the bucket of quality of end-of-life care. So that's what when I say quality of end-of-life care in the context of these studies, that's what I'm talking about. The other is this issue of advanced care planning, which is something that I've alluded to. Advanced care planning is when you either informally or formally state what your treatment preferences are for your care at end of life, and you do it ahead of time. This can be informally in the way of a discussion with a loved one or a physician, right? Medicare has recently started reimbursing for these types of discussions with physicians. It can also be formally by naming a healthcare proxy to make decisions on your behalf, or by executing what's called a living will or an advance directive where you state what you would or would not want to happen. And again, as I mentioned earlier, advanced care planning has been linked to less aggressive care overall at end of life and to achieving care that's concordant with your preferences. So in the first study, I'm looking at caregiver assessments of end of life quality by race and ethnicity and also by dementia status. This is about 1,500 people from the NHATS state sample, and I use these nine different measures of end-of-life care quality together in a latent class analysis. And what I find surprisingly, right, given that people with dementia and members of racial and ethnic minority groups are likely to receive aggressive, burdensome care, right, that they're likely to not live as long, that there's a heavy caregiving burden. Surprisingly, I find that non-Hispanic Blacks and individuals with dementia are less likely to provide negative assessments of care. So that means is that they rate care more positively, end-of-life care and the quality of care more positively than caregivers for non-Hispanic white individuals and for people without dementia. And this is in a fairly robustly adjusted model that accounts for all kinds of other things. So to me, this raises the question, like, what's going on here in these data that you're getting?
It's the best care mom ever got.
That could be. Unfortunately, the data don't allow us to go there, but that is something that could be. The expectations, right, are much lower in terms of what they received in the past. So that might be a possible explanation in terms of non-Hispanic Black individuals. Maybe a little bit less clear. And there is probably a slightly different mechanism going on in terms of dementia. Something that may be happening in terms of dementia is that the caregiving burden is already so great and so extended, and you've in some ways already lost the person. A lot of people, there's evidence of anticipatory grief and having lost the person before they die, that in some instances, death may be more of a relief. In the second study, I look at advanced care planning and sadness and anxiety in particular at the end of life, and I look to see whether or not that differs by race. Okay? And this is a smaller sample because of the way that the survey was done and skip patterns in the survey. And I use moderation analysis. And what I find is that the relationship between advanced care planning and caregiver assessments of whether their loved one experienced sadness or anxiety in the last month of life absolutely differs by decedent race. And as much for Blacks, it's a negative effect by a factor of 2.5 or greater, whereas there is no effect or a trend in the opposite direction for non-Hispanic whites. And I want to just sort of illustrate what I mean by that. So this shows the predicted probabilities of that the patient has unmanaged sadness or anxiety in the last month of life. And the red bars, this is for end-of-life discussions, and the red bars are amongst non-Hispanic Blacks who had no discussions and discussions, and the blue bars are non-Hispanic whites who had no discussions or discussions. And you can see that proxies for non-Hispanic Black individuals with discussions have a predicted probability of saying this person experienced sadness and anxiety and nobody helped them with it at more than 2.5 times the rate. So it's a 16% predicted probability with no discussions and a 40% predicted probability. So almost half, right, of respondents. Whereas for non-Hispanic whites, you see a trend in the opposite direction. Now this is not a significantly different result, it's marginally significant, but it's trending in this way, and as waves of data allow us to increase sample size, that this may in fact become significant. When we look at healthcare proxies, right, so when you name a decision maker, we see an even stronger effect. It's over 3.5 times the effect of naming a healthcare proxy, and no effect amongst non-Hispanic whites. So I find this puzzling as well. So overall, these lead me to a couple of questions. The first we sort of discussed, like, why do caregivers for non-Hispanic Black individuals and those with dementia rate care so much more positively? It could be about a question of expectations. It could be, the effects of prolonged caregiving. And then with the second one is what causes these increased reports of unmet needs related to sadness and anxiety amongst non-Hispanic Black individuals who complete advanced care planning, right? So like you would think they've said what they've done what they're supposed to do, and there's something going on where they're not, where they're still experiencing angst and discomfort at the end of life. So, two possibilities are that it's something about the process of advanced care planning for non-Hispanic Black individuals, that there's something going on that then carries over into end of life. Another possibility is that there's something about what the type of care that non-Hispanic Black individuals who plan for end of life are receiving that is just it's not working. There's something that's not working for them. So this sort of raises a lot of, this is the great thing about research, is when it raises more questions than it answers. So looking ahead, I've got a couple of current research projects. One that continues to use this NPATS data and looks at the National Study of Caregiving, which is a companion study to NPATS, that looks at caregiver characteristics. So how the lived experiences of caregivers, both their sociodemographic characteristics as well as their experience of caregiving. Do they have caregiver burden? Are they satisfied? How long have they spent caregiving? How does that relate to their perceptions of end-of-life care quality? And then another one that tries to get at this, what's going on. So it's a qualitative interview study with a diverse group of caregivers for community dwelling individuals with dementia. And this study answers some kind of questions like what kind of knowledge do caregivers have about end-stage dementia, about hospice, about palliative care and advanced care planning? What are their expectations for what's going to happen, and what are some perceived challenges they think might come up in terms of helping their loved one get the type of care and support that they need. This fits into sort of a larger research agenda that looks at equity in hospice care for patients with advanced dementia. This is sort of the obnoxious conceptual framework that I use to sort of help me navigate through this process, but I want to break it down a little bit. So as a sociologist, it can be broken down into sort of constituent sub-studies. So as a sociologist, I'm interested in processes like race and ethnicity and socioeconomic status. And one of the things that is sort of lacking, at least in the medical literature that looks at some of these disparities in end-of-life care, is that they don't untangle the difference between sort of what's an issue that's related to race and ethnicity and what's an issue that's related to access to resources, because we know that race and ethnicity is highly correlated with socioeconomic status in this country. I think that's a really good point, right? So one of the things that I want to do is begin to untangle and look more carefully at what are sort of the barriers that are related to socioeconomic status and what might be related to race and ethnicity. Now, in a group of clinicians, and you all are translational researchers, so you've heard this before, right? In a group of clinicians, the feedback that I get is great, but what can we do about that, right? We cannot, or we want to change somebody's lived experience of their race and ethnicity. This system is not set up in this country to help people in terms of socioeconomic status. Like those are not policies that are going to gain a lot of traction. So one thing that we can do is look at what we call modifiable factors, right? Things that you can target, that you can begin to understand and then target and intervene on to try and change outcomes for people. So in the context of hospice care and the progression of Alzheimer's disease, I look at knowledge and understanding. So knowledge about hospice care and what it might provide, right? It is not a panacea for everything. It cannot be all things to all people, but people who are unfamiliar with hospice may not understand that. And I look at understanding of illness progression. So what do you think is going to happen? Do you understand what's going to happen as your loved one's dementia progresses? And this fits in with people's expectations of what they're going to get, what type of resources they're going to have, where they can get the resources, what type of help they're going to need, and where they're going to get the support they need. And we can look at how knowledge, understanding, and expectations vary by sociodemographic factors, race, ethnicity, socioeconomic status, as well as an individual's beliefs and value system and their past experience, particularly in the case of racial and ethnic minority status, with perceived discrimination and institutional racism. All of this can come to bear on outcomes of importance, right? So I put these outcomes into sort of two buckets. One is the type of decision-making that occurs through the course of hospice care. So are folks having goals of care conversations, and what's the content of those conversations? Are they completing advanced care planning as part of hospice? And what is the timing and the content of those decision-makings? And ultimately what that means in terms of hospice outcomes. So are people being discharged alive? How does this relate to whether or not they experience a life discharge or avoid a life discharge from hospice? Their level of satisfaction with care. And satisfaction with care is always like a tricky one. Clinicians don't like that either, because it's like, wow, somebody gets mad because they can't find a parking spot, and then that blows the satisfaction with care rating. There are complex measures and multidimensional measures of satisfaction with care that I think we don't want to just completely discount. The other reason satisfaction is important is because it matters for family caregiver long-term health and well-being. So their perception of what happened, whether it's all about the parking spot or not, right? If you can understand that, that actually has real implications for their own long-term outcomes. So I'm going to leave it there with a little bit of with a big thank you out to different funding sources, to the folks here, to the ones at Weill Cornell and Behavioral Geriatrics and Palliative Care and the Center for End-of-Life Research, and in particular to Holly Ferguson and Carrie Reed, who I've been working with closely. So thank you.
Well, the individual presentations were fantastic, but also I think we can see some interconnections, among them. Because we do have a little time for questions. So whoever would like to begin.
Yeah, Lee.
So I wondered whether that second paradox you identified, whether or not you had been thinking about the research that's been done on racial disparities in the effectiveness of healthcare communication. There's a fair amount of research on that earlier in the life course. John and Sonia McKinley,
Okay.
for example.
Now, so that was actually the second study is still in progress. So that would be a great thing to be thinking. I can't measure the effectiveness of communication, but I certainly that could be an explanatory.
Right, or think about it as a follow-up at some point, because they work in the translational piece all the time in Boston area hospitals, so they've done that.
Thank you.
Really basic question, because I don't know much about this at all, but I'm wondering if there are cultural differences, like cross-cultural differences in the trajectory of Alzheimer's. If you look, compare, say, the US with India or something very different in terms of culture. Does it tend to
Can I piggyback under that? Because mine is so similar. And it sort of applies to both, but I was wondering too, culturally, you talk sort of demographically, but I was thinking culturally, like, is a disease even conceived of differently? I think I had my beloved and late Scottish mother-in-law who would talk about her, now we would say, demented grandparents, but they were sort of potty, and they kind of looked after them and steered them. It just sort of wasn't as, I hate to put it this way, like it wasn't as big a deal in some way or as medicalized. So I wonder, like, if other cultures treat it that way. I don't know if that is related to your question or not.
Yeah, so I think that's an important consideration in terms of it, because my first was I was like, in India, do they have information on Alzheimer's in India, and what type of data what would it look like, and how would it be, as the diagnostic criteria the same? I think, one of the things that is really interesting, Carl mentions the medicalization of different sort of social processes and social experiences, and with Alzheimer's, that's an interesting question, because we don't live in a society that allows, that I can tell. There may be anecdotal exceptions to this, but overall we don't live in a society that sort of allows for somebody to be dotty and putz around and sort of bounce gently back and forth from one place to another. And because I speak in terms of demographics, because it is going to be a huge problem. I mean, we know that there's sort of a demographic explosion waiting to happen. So I find that cleaner. But you're right.
The Q work, I would think, for example, like our issues like cultural compatibility or race or ethnic matching between provider and patient, for example, in terms of how information is communicated, it would seem to me that the same kinds of sort of ethnic and cultural variables would be important considerations. Is that-
Yeah, I can definitely see that too. I think, thinking about that, that's something that'll be really important for me to incorporate as I'm moving forward. I don't know that I can speak as much to that now, but I think it's a really important consideration.
I have a question for Heather. So I was thinking of healthcare encounters of the kind you're studying. I think the model we tend to think of is the primary care encounter and so forth, based on a doctor, where often in these kind of oncology settings and so forth, there's at least one other third person involved. There's either the nurse who takes you in and gets you set up and takes your blood pressure and asks you about your symptoms and so forth. So there's an encounter before the doctor ever comes in and talks about your skin results.
Yeah.
Or there's even a junior doctor, the fellow comes in, does the initial exam, has an initial conversation, then the senior person comes in and sits down with you and says, okay, let's talk about why the fellow may be still there in the room.
Right.
So it's a little more complicated social interaction. And I'm wondering whether those are also points of intervention as well, because in terms of relaxing and intervening with somebody, maybe that other person, whether it's the nurse or the fellow or things like that, that would actually more be the point of intervention rather than maybe the physician.
Or a patient communication specialist intervention.
Yeah.
Because often when you call too, you talk to the nurse, you talk to a nurse or something, it's rare you have doctors.
And I'm thinking the visit itself.
Yeah. I think that's a great point. I'd be really interested in kind of what goes on naturalistically in that interaction, and then also, like you mentioned, might there be different people as part of the team that could more or less easily kind of, prompt or be a part of an intervention that would happen during the visit. Yeah, I think that's a really, really interesting point to possibly get a foot in the door.
Let alone family members sometimes invited into the room. too.
Absolutely.
And that just complicates it.
Yeah.
For work.
Yeah, I think a lot of what I'm interested in really extends to family and caregivers as well. I'm kind of just biting off a really narrow piece right now, but I think it's excellent point. Yeah.
Yeah, just my father just had advanced prostate cancer and was diagnosed a year and a half. I went to in Michigan at the med school, University of Michigan. Med school is where I was going, and I went with him to a couple of appointments with the oncologist, and just to address that, we spent a lot more time with the nurse practitioner. She was always the front line, and she had a personality that was a lot easier to talk with, and there could be real differences there. And the oncologist was always really busy. He was great also, but he was in and out, and But what was interesting and really why this whole stress thing, my father's an academic, and yet he would sit there reading his New York magazine, and the oncologist would come in and he would sit on the bed thing, whatever, and he continues reading this, which is like bizarre, And then on top of that, he never read up about his condition and prognosis and all of that, and just very unusual for him, because usually he's reading all kinds of stuff. My mother, me, all the rest of us are, trying to find everything we can about the option. I read this guy's oncologist research articles and whatever people are putting in. So and now it sort of, was it his coping mechanism because of the stress, or does he just have that much faith in the medical community? They're going to do whatever,
I wonder, I was thinking about that too. I wasn't going to say anything, but it makes sense. Link it here, because I wonder about if there's any kind of measure of sort of relationship to death or the idea of dying, because I saw the same thing with my mom. It wasn't the same mechanism, but she just couldn't grapple with this idea that she's actually going to die, and it really showed up when she went to the doctor. Whereas if somebody, depending on the relationship they have, the set of beliefs they have, that's one of the reasons why I asked the cross-cultural question, because I have a feeling that maybe some of the narratives, the cultural narratives might matter. It would be really interesting.
You guys also, you do a topic where like none of us can resist our own. My mother-in-law was up like, things like those sound like kind of denial, but for her, a lot of the anger about her illness was channeled at the medical professionals. So that it was hard. Her distraction wasn't anxiety. it was anger and having to be there, having to have them tell her these things, and often like was like their characteristics were like infuriating her, even though they would seem to an outsider. So it seems like sort of a complex emotional situation that it would be great to disentangle.
My mother was always very sweet. And so she set up the conversation so the doctor couldn't tell her anything bad.
Yeah, that's an interesting strategy too.
I think there's also a generational thing going on here. I mean, there's not a specific line, but we were growing up. The doctor and the medical people, they were like the bosses. And you didn't question, and you expected them to tell you what to do. And this is kind of changing now, and I think people have caught somewhat in the middle of it. So you're going to have some people that will still like whatever he says is fine with me, and other people are going to be just questioning everything and doing research and being the internet doctors.
Yeah, absolutely. I think it's a really interesting point that you bring up, because I can think of a few clinical experiences that I had where, we're trying to, make goals based off what maybe the patient wants to talk about. And they say, well, aren't you supposed to be telling me what we're going to talk about? So it can be really confusing, I think, for people. It's a great point.
I was going to mention, I wrote down the anxiety, specifically because I have a friend who just finished a whole bunch of stuff, and she's young, and she has young children, and her first and foremost anxiety came from what happens to my children. But one of the things that she had mentioned while she was going through the process is the last scan that she went to, she had this meltdown. She was like, I don't even know where it came from. I've never experienced a panic attack, any kind of something like this before. And that kind of elevated it, right? She was like, I've never experienced anything like this before. Something must be wrong. Something else must be wrong inside of my body for me to have this kind of physical reaction to just getting this scan. Luckily, she had her sister, who was very convincing to the radiologist to let her in and be in there with her, and it brought it down a little bit. But I think I wrote it down because I'm going to text her as soon as I leave and be like, listen, this is a thing. This happens. And so I'm wondering if even something like that, just knowing that it's an actual thing, like people you could have gone through, a bunch of scans before. Yeah, like kind of like it's and telling people beforehand, like, listen, here we know some of the physical things that happen, and these are going to be some of the side effects, and these are some of the other side effects that we didn't even know about beforehand, but just so you know.
Right.
Because I think that will help her. Honestly, I think that's probably one thing that'll bring down her own anxiety, and the motherhood thing was just something that I was in the back of my head, because there's just that added what happens to my children.
Yeah, I'm glad to hear that might be helpful. I think just to kind of further in some of the studies that I was looking at with this, it was like one of the top 10 concerns was the anxiety about appointments, but I think first or second was anxiety about what's, family, how's this affecting them, what's going to happen to them. So extremely common.
Well, all right, if you feel like you have appointments right away, or if people want to chat with you, will you be here for a moment?
We'll be here for a while.
Well, thanks.
Yeah, thank you.